Good afternoon, everybody. My name is Garrett Schmidt, and I am the managing editor for ACO Exhibit Hall. And I'd like to welcome you all to today's live panel discussion hosted by Salient Healthcare called Gaining Market Share as a Benefit to Value-Based Organizations. We have a great discussion in store for you, so glad you're here. A few items of note before we get started is all attendees have joined today in listen-only mode, so you don't need to worry about muting your mic. That's been done for you. And I'd like to let you know that the webinar is being recorded so that you'll have the opportunity to rewatch the session or share it with colleagues, and hope you do so. And a link to the recording will be emailed to you following the presentation, and it'll also have the slide set that you can download there. So, and I'll send that out to you afterwards. Lastly, during the webinar today, you can submit questions, and we encourage you to do so to our presenters using the attendee control panel. And you don't have to do that during the Q&A session. You can do that at any time during the presentation. And we'll get to as many of those as we possibly can during the Q&A session at the end. We've got a lot to cover today. And while doing so, please specify if a question is directed to a specific panelist, and that'll help us. And the questions are being recorded, so even if we're unable to get to yours, we're going to make sure to follow up via email to answer them afterwards. So please, please ask away. Sitting on our panel today is co-founder and director of Cura Health, Miss Marsha Boggess, and the Chief Operating Officer of Palm Beach ACO, Mr. David Klebonis. Our moderator today is Amy Koch, the Principal Business Consultant with Salient Healthcare. And at this time, I'm going to hand it over to you, Ms. Koch, to get us started. Welcome.
Thank you, Garrett. So good morning or good afternoon, everybody. And I'm really honored today to be joined by our two panelists to discuss gaining market share as a benefit to value-based organizations. So just a brief background on two of our panelists, or we'll go through everybody. So Marsha is the founder and managing partner of Cura Health Management, which is an enablement company for accountable care organizations and other healthcare provider networks in the value-based payment arena. And that company is now a division of HealthLinked, which is a corporation of Naples, Florida. She's also the managing director of ACO Health Partners, LLC, a Cura Health Management owned and operated ACO. She also works with a number of other ACOs under the company umbrella. So there's a lot of experience there with different organizations. Then we have David Klebonis, who began with Palm Beach ACO in 2012 as part of the original executive team. David has a business and technology background with a penchant for helping physicians increase their income through better processes, technology, and execution of value-based initiatives. Now, some of you might not know, but Palm Beach ACO is a physician-owned and operated network of approximately 325 independent primary care physicians and 175 specialist physicians. They're ranked first out of 548 MSSP ACOs nationally. And in 2018, they had shared savings of over $50 million. And since their start in 2012, they've had cost savings of $386.8 million. So a lot of savings under their belt. It's one very large ACO, whereas Marsha is coming from a more of a management perspective of multiple ACOs. Lastly, myself, my name's Amy Koch, Principal Business Consultant at Salient Healthcare. We work with a number of value-based organizations. We do have a large chunk of that business under the ACO model. And today I'll be acting as a narrator throughout the presentation to highlight our panelists' experience. And myself included, I've had quite a few years of experience with ACOs, MSOs, technology companies, and pharmaceutical consulting. So you'll be able to glean a lot of insights. We're going to share with you today what has worked and what hasn't worked, so that you guys can take some information home with you. Now, before we dive into the meat of the presentation, I think it would be insensitive for us to not just mention a little bit about COVID-19. It's affecting everybody. So David has put together a little bit on how at-risk organizations are going to be affected.
Great. Thank you so much, Amy, and good afternoon to all. So it's an extremely relevant question during this emergency. It comes up often is how will the emergency affect ACOs? And Medicare has honestly been thinking about this since 2017, and they're going to treat it similarly to other emergencies like hurricanes and earthquakes and fires that have all been relevant over the last few years. But if you read the rulemaking, they address it under extreme and uncontrollable circumstances. And the summary, which is not nearly enough, so please reach out to Amy if you have more questions, but the summary is that Medicare will update your benchmark during an emergency based on the trend in your market. So if costs go up by 10% in your market, then so will your benchmark, and you'll be compared to your peers. Very relevant during this emergency is if costs go down by 10%, Medicare will also update your benchmark to go down, and it'll be harder to achieve cost savings. So the big question is, who are your peers? And this slide shows that depending on when you started and when you renewed, you may be compared to different peers, whether that's national or regional. How do they treat quality? So Medicare does have a generous approach here. Is they will either give you the higher of the two of your actual quality score or the national average. So if due to the emergency you have a really tough time in quality, you do get a benefit there. And then the third major way that they address an emergency is that if you are a downside risk ACO, not upside only, but if you're downside risk, they will prorate your losses based on the portion of the year and where your beneficiaries are located in the emergency. So if you lost $1 million and that 50% of your beneficiaries were in states with an emergency, they would prorate your losses to $500K. Thank you, Amy. And by the way, Amy is going to be your source if you have any additional questions.
Thanks, David. So I'm next going to push it over to Marsha, who's going to talk briefly about how telehealth has impacted providers and what's going on that front line.
Thank you, Amy. Yes, from a provider perspective, in addition to the availability of some of the stimulus monies, be it the paycheck protection loans or the economic injury disaster loans, or even the CMS advanced payment provisions, there's a recognition by CMS that continued access to care is important during this public health emergency. So they responded, in my opinion, fairly early to that and said, starting March 1, that we're going to be in a position where we can actually expand the telehealth provision of the CMS guidelines. So specifically what they did was that they lifted a lot of the restrictions that we were familiar with as it related to the use of telehealth services during the COVID-19 emergency. And some of those key changes were that they expanded the pay for services at the same rate as the in-person, which was huge. So literally a telehealth visit could be provided and be reimbursed at the same rate. Obviously, this helped a lot of providers be able to quickly get on board with the technology if they weren't using it already, and be able to reach out to their patients and engage them in that way. Obviously, it was a learning curve for both, and is a learning curve for both the provider and the patient, but we're seeing some really good advances in that area. The other thing that they did is that they expanded the eligible qualified health professionals that were eligible to be providing telehealth through the platforms, and that was helpful as well. They also expanded the list of services that could be reported via telehealth. They included more sites of service. You may recall that in the past, if you weren't in a rural environment or if you weren't in a designated area within a facility that was recognized as being appropriate for telehealth, you really couldn't bill and be paid for the telehealth services. SNF was a perfect example where telehealth was not a recognized provider location of service. So they expanded that to be just about everywhere, including home, which has been very helpful. The CMS also permitted the reporting of the E&M visits, both in the office and outpatient, based on time or medical decision making, as opposed to a lot of documentation that was formally required in order to get reimbursement. They clarified that the telehealth services could be permitted for both new and established patients. Again, in the past, pretty much meant for established patients, but now new patient visits can be conducted via telehealth. And that's been very helpful, and including the ability to do the annual wellness visits. So we've been encouraging our providers to really embrace telemedicine, to stay engaged with their patients, and to even conduct their annual wellness visits as a way to help not only the patient, but obviously help with attribution. There's some increased payments that were made for some of the codes during this time for telehealth and related services. One of the biggies surrounds the phone call reimbursement. You may recall that phone calls were not typically reimbursed by CMS. Now CMS does reimburse for 3 codes related to telephone interface, and this helps with those patients that are just not comfortable with the technology, the app technology. And those 3 codes pay anywhere from $17 to $45, depending upon the time that's spent. Licensure across states, very much relaxed. Some of our providers were able to quickly be recognized across state lines and start providing care. Obviously, it's still dictated by the licensure rules of that particular state, but we've seen a lot of leniency in terms of recognition, and thus we have providers that are providing telemedicine across many state lines. And for us, that's very important because our ACOs, our ACO population, the one that we own, is in multiple states. So it's allowed our providers to increase their reach. And then certainly last but not least, we have CMS authorizing some of the platforms that the patients and the providers were more familiar with. Skype, Zoom, WebEx. Some of those platforms were recognized by CMS as being appropriate to conduct a telehealth visit, which in some ways gave a little bit more leniency to some of the HIPAA rules. So we've seen a real embracing of CMS for telemedicine, and we're seeing our providers really make great strides in terms of using it.
Thank you, Marsha. So I think you got a really nice brief overview of how COVID is affecting providers and just a little bit about telehealth and how that's being used. So let's get into the meat of our presentation, which we came for today. But know that you can ask us any questions about COVID. We're here to help you. So here is a slide. It's just showing you a bunch of headlines about mass consolidation, that we know that ACOs are joining forces. They're either being acquired or merged together, and that's just happening around the country. But we also know that Medicare beneficiaries are increasing. We know that the patient population is increasing. And on the left-hand side, you can see that there was a peak in accountable care organizations in 2018 with a slight drop in 2019 and 2020. However, the covered lives have been on the rise. So we know that there are mergers and acquisitions. And on the right-hand side, we know that quality has not been compromised as indicated by the purple line, and that the total shared savings have also increased year over year. The next slide is a picture from the CMS website, and this is an interactive map. So right where that purple dot is with the number isn't necessarily exactly the location. You got to zoom in on that map because it's interactive. But this is a look at the 2020 listing of ACOs and where they're located. Our 2 panelists today, and actually myself included, are all located in Florida. However, under the Cura Health Management umbrella, some of the ACO members are located throughout the country. But just take a look at where the majority of ACOs are located. It's typically in the South areas. Florida definitely has a large chunk, so you're getting experience firsthand from people who have been doing this since 2012. To level set, and I think it's really important that people understand exactly what plurality of care means, because when we talk about gaining market share, it ultimately comes down to plurality of care. And this is the definition CMS is using to identify which patients are attributed to which providers. And it's the true provider who's providing primary care services as indicated by CMS. Now, the first step in this two-step process is to understand if the provider is a primary care physician or specialist. And in this segment here, you can see that the third provider is a specialist. So even if they have the most amount of dollars spent under them, by having that specialist title, the designation wipes them out from being included. Now, looking at primary care physician 1 and 2, you would give plurality of care to primary care physician number 2 because they have the most amount of dollars spent under them. So it's who's providing the most amount of those primary care services. So I'm going to pass this over to David and Marsha. They're going to talk about why market share is just so incredibly important for your value-based payment contracts.
Great. So I want to give some perspective as this is our 8th year as an ACO, and these were some doors that were open that were surprising. So as a large ACO or a high market share ACO, it really opens doors for more risk-bearing arrangements. So the number one obstacle to getting a risk-bearing arrangement is that you don't have the minimum attribution. So the payer wants to make sure that you have 5,000 to 10,000 lives under their attribution so they can fairly measure your performance and pay performance payments. And what you find if you're a medium-sized ACO even is that you'll meet your minimum attribution for Medicare, and you might meet minimum attribution for your largest payer in your market. But what's really nice is if you're a high market share ACO, you have a lot of patients. So you'll find yourself hitting minimum attribution and ability to contract with your 4th, 5th largest payer in your market. And that makes it really convenient for the doctors because every single patient roughly is under value-based care.
So just moving beyond that and talking a little bit about group purchasing, I often see this as a missed opportunity for some of the ACOs that we're either aware of or sometimes we're even working with. So one of our opportunities that we embrace first is to look for opportunities to actually play on the aggregation of all of these providers and to really leverage that aggregation to help those providers save money, basically running their practices. And a few key areas that come to mind are, first of all, health insurance. In days past, in order to get benefit of a group health insurance policy, one had to have a common payroll system. So those rules have been relaxed, and our health insurance organizations are recognizing large organizations that are aggregated, and they're particularly interested when they're aggregated around a risk management model, because their perception is if they're managing risk associated with costs and quality, they're going to manage their own risk as it relates to health insurance spend. So they're now very interested in quoting for health insurance. Also malpractice insurance. A lot of the malpractice carriers are also very interested in working with ACOs to provide better rates. And in some cases, the malpractice insurance carriers are able to actually qualify as a waiver partner to come in and help provide some services, help provide some of the some cost assistance with running the infrastructure. And it's really a nice alliance because, again, we're all working in the risk space. Also, medical supplies and office supplies that are all major cost drivers for our participant practices. Now, the size brings negotiating power, and in today's environment, and in terms of that negotiating power, it also brings sometimes access to particularly supplies. Many of our practices are trying to get supplies in this COVID-19 environment, personal protective equipment, and some of the larger ACOs have been able, because of their purchasing power, to be able to actually acquire some of the PPE for their participant practices, where the smaller organizations or the single practice environment does not allow for that very well. Next up would be thinking about the single platform. To use a single platform, which is needed for analytics and reporting, it not only drives the cost down, but it really expedites the availability of information. And I think probably Amy could speak to this, for a couple of days, but just having the ability to aggregate all that information on a single platform really helps drive the costs down. And we've worked, I think, very effectively with Salient to have them recognize the size of our ACO populations and recognize that from a pricing perspective. But also it allows to get that information to the providers in a more efficient manner. So we know that time is money. We know that the most real-time information that we can get, the more actionable that information will be. In addition to that, we love it when we can also marry a single EMR platform to that equation. Obviously, that's not always the case, but when we can, we love to marry that single platform EMR with a single platform for analytics. And again, that helps expedite the process in terms of getting real-time information to the providers around which they can take action. And it helps with reporting costs, et cetera. And finally, the size brings name recognition in the marketplace. So not only does it help us when we're talking with suppliers and vendors for purchasing insurance and supplies, but it gives us a lot of credibility in the marketplace. The third-party payers take us more seriously when we're larger. And because we represent to them the bandwidth, the sustainability and security, and not to mention the robust patient population that they're really looking for. So they feel more comfortable negotiating not only around fee-for-service, but often around the value-based programs, because they feel like that there's the ability to really succeed given the size of the organization. And just to jump across the slide deck here, finally, we all recognize that there are large upfront costs associated with starting an ACO. We started a couple of ACOs from scratch, and it's very, very cost and labor intensive to do that. So joining a pre-existing organization is often a very good solution to avoid that startup burden. And then the large ACOs obviously are able to share the ongoing cost of sustaining the organization and supplying the services to the organization. They're able to spread those costs across that larger population. So therefore, when it comes time for the rewards, there's a smaller per capita cost associated typically. So you're returning a larger share of that shared savings to the stakeholders when success does come. And I think these are all things that are very good selling points when you're trying to recruit a new TIN into your practice.
Excellent points, Marsha. Now, our life changed when we became a meritocracy. So that means 100% performance-driven organization. So we've been beholden to really politically affiliated physicians or a very large group, and I've seen this hurt other ACOs. And when you're large, you can afford to part ways with a physician temporarily. And I can't overstate is how much it improves the engagement if you can take a pause, everyone kind of understands what they miss. And then when you pick up a year later because you're large and you can afford to, it really, really helps the overall engagement.
All right. So there are definitely a lot of pros to gaining market share, and we're going to talk about 4 different ways to do so. So we're going to go through what continuous attribution means, making sure you're keeping the patients that are attributed to you. Then we'll talk about how to gain new patients through the Assignables methodology and through new patient strategies. And then lastly, we'll talk about how to add new practices or TINs to your organization. So let's start with continuous attribution. Now, it is extremely important to ensure that you're keeping the patients that are attributed to you. It's not so much about the net number. Of course, you need to hit the minimum amount of patients in your organization as indicated by CMS, but having a low churn rate is absolutely an important key in basically figuring out predictability. churn rates affect your variability. So if you're not keeping your patients consistent over time and the care isn't consistent over time, you won't be able to predict final outcomes. Now, here's a study that we did with one of the ACOs that Marsha works with, and you can see that there are two different populations. The top population has been continuously attributed, and you can see their spend is about $14,000 per member per year. Yes, we're in Florida, higher spends. And their risk score is about 1.33, and their wellness visit completion rate was about a 26.3%. Now, if you compare that to the non-continuously attributed population, you'll see that the spend is actually $2,000 per member per year more. And then also the wellness visit completion is a lot lower. So we use wellness visits as a proxy for quality, and you can be rest assured that it's really hard to manage these patients and ensure all quality metrics are met when they're just not continuously attributed. They're not seeing their providers enough. So let's talk about how you can decrease your churn rates. We always go to the first item on the list, which is wellness visits. Annual wellness visits absolutely help you decrease the churn rate. They help the patients develop a relationship with the provider, and also for that factor of plurality of care. You can see here on the top of the screen, we have an average reimbursement rate of $152.40 for a wellness visit with the same ACO, as compared to an E&M visit. On the bottom, you can see the average charge is about $70. So you need to have quite a few E&M visits to even total how much a wellness visit will reimburse you at. So just plurality of care is a great way to, or actually wellness visits is a great way to ensure plurality of care. Marsha, did you want to touch a little bit on this as well?
I'd just like to add that we've used this slide a number of times with physicians who just are somewhat resistant to doing annual wellness visits and insist on, opting for the seeing the patient, when needed for some sort of disease state as opposed to a wellness visit. And so we've used it not only from a reimbursement standpoint to show them, how much harder they have to work for half the reimbursement, but just in terms of what it means to them from an attribution perspective. So again, this kind of perspective is very powerful when I think coaching the providers.
Absolutely. And another thing that's really nice to take a look at is going to be the percent seen on a quarterly basis. CMS tells us that at least 70% of the Medicare population has one or more chronic conditions. So at least 70% should be seen on a quarterly basis. And David, you want to touch upon how you use this metric?
Absolutely. So this is a lot different than average visits per year. So you can have a COPD or other exacerbation where you see the patients 5 times in the quarter, and then they would show up as, roughly 1 visit per quarter. But what you really want to measure is, are your physicians, treating these patients regularly and making sure they can manage the chronic disease? So, by measuring the unique patients in each quarter, you can definitely get to the root cause often that your practices aren't closed loop and they're not seeing they're chronically ill enough.
Yeah. And then the other proactive method is actually seeing patients who have not been in the office in the past 6 months. And Marsha uses this with her practices as well.
Yeah, we use this data quite a bit, and because we see this population as at risk, and from a number of perspectives. But the 2 key ones would be, we feel like that they're at risk of losing attribution for them. We haven't seen them in 6 months. We don't know what's going on with them from a health perspective. Perhaps we've not scheduled their annual wellness visit. So we need to really engage with these patients because of the attribution concern. But the second concern is perhaps we're not at risk losing them from an attribution perspective, but we're at risk of losing them from managing some chronic disease state or illness that they have. Maybe this is a patient that has a cardiac condition. Maybe they fall into that unmanaged cardiac situation where we would really need to see them at least once a quarter and make sure that the cardiac plan that's been put in place is really being executed. So this patient could be clinically out of control if they're in one of those categories. So we use Salient not only to give us this information, but also to give us more specific information about these patients to understand what are we doing for these patients in our practice? What has been their history? Are they part of our chronic care management program? Should we be seeing them, not only every 6 months or once a year, but should we be seeing them more frequently?
Absolutely. How you maintain your current population? We're going to move into assignables, which is still the population that your providers are seeing, but they just haven't gained attribution yet because they haven't received that plurality of care. So a very quick definition of the assignables, it's, if you take a look at the left side of your screen, you'll see all the patients that are seen in the practice. Maybe there's 1,000. And only through the plurality of care logic have a certain portion been attributed to your provider. So maybe 400 of the 1,000 have been attributed. There's going to be a leftover population that are still being seen. They just haven't had all of the services with that provider per se. So you could actually reach out to this assignable population to gain attribution, and they're already within the practice. So David's going to talk about how using the assignables can be really helpful.
Absolutely. So when people hear grow their panel, they may think that they have to bring in new patients, but the reality is there's plenty of opportunity to grow your panel within your assignables. So, a statistic that we work on a lot is that 40% of our patients are won or lost just by one visit in a year. So that means that if we're able to use this report and see our patients one more time as medically necessary, we'll be able to secure the patients that are already assigned, as well as to significantly grow our panel. So we work a whole lot on this every year.
Yep. So the next thing we're going to talk about is the new patient strategy. And some people, think about cherry picking when you talk about this, but we want to talk about what is the right strategy and how do you actually go about it. So David and Marsha are going to talk about some of that new patient strategy with you.
So I feel like folks get mixed up with the goal. So you don't want any new patient. You want new patients that are average. You want new patients that are going to give you a fair shake when being evaluated under these value-based programs. And the source of the new patients is a very critical question. So if most of your practice is office-based and then you start acquiring new patients for the first time from the ER or hospital call or SNF, those patients are going to be a lot more expensive than the ones that are in your benchmark. And it's going to make you look like a bad doctor. So we're just cognizant to ask these questions to our doctors to make sure that they're getting patients that are going to give them a fair evaluation and not immediately ruin their numbers. The other comment is, your patients are going to pass away. And if you want to maintain your panel, you have to have a healthy influx of new patients. And boy, the last question on here is, if a patient has to wait 3 weeks to get into your office, you're not going to get many new patients. So that's one of the first things we troubleshoot to make sure our practices are getting new patients.
Right. So just to build on that, particularly the last one, we often see, because we have the data, somewhat of a remarkable decline in attribution when we see our providers are approaching retirement, or they are struggling with an illness, or maybe they've assumed some other responsibilities that take them away from their office environment and thus their availability for the practice. So we use that data to identify those trends with the providers, and then we try to take a close look at those doctors and understand what's really happening. And sometimes we find that they are approaching retirement and they don't really have a plan. They don't have a succession plan for their practice. So often, even though it may seem outside of the norm for an ACO in terms of its service offering, we'll go in and say, can we help you? Because your patients are waiting a long time for an appointment. We've seen a decline in your attribution. We assume that you don't want your practice to just dwindle away, but how can we help you? And that might take the form of finding someone to help them with a succession plan, or participating in that with them. It might be helping them recruit an additional provider, another physician, a mid-level practitioner, or any other interventions that we might assist with to really keep that attribution, keep that physician hopefully where they want to be, and continue to provide access to care for those Medicare benefits.
Absolutely. So our last method is adding new practices. And this is always an interesting point because there's a contract that's required between the ACO and the practices. And CMS has some guidelines around that, but it's really important to take a look at what works and what doesn't. You can't just use the bare minimum. You have to use your experience, or maybe David and Marsha's experience, in how to actually create that contract. So let's talk about what works and what doesn't work in this perspective.
Thanks. Yeah, beyond we all know what CMS requires in terms of certain things within your participation agreement. But really when we're defining the contract between the TIN and the ACO, we're going beyond just the CMS requirements. And we're saying, how does that come alive for each provider? And we start with, trying not to leave anything to chance, trying to make sure there are no big surprises to this provider as they go into this relationship and they perform within the confines of this relationship. So we really try to make sure that each provider understands what their responsibilities are, what they can expect from the ACO in terms of support and guidance. How often will they be getting information, and what kind of support will they get to make that information actionable? So getting somewhat granular with them in terms of understanding that real contract. So we think it's important to start off there. Part of that is just understanding up front what the financial distribution model will look like. And in some cases, the ACO board may still be working on some of that, but in some cases it may already be defined. So either if you know it, talk to them about it. If you don't know that, tell them that it's forthcoming and then follow up with them. But make sure that they understand, what's the carrot and how will it be determined. So that will help you with, having the providers focused on attribution, on managing the costs, on documenting quality, all the things that we need for an ACO to be successful. If they have the eye on the prize and there's specifically a pathway to get there, we found that they're much more likely to be cooperative. And then providing ongoing analytics regarding performance. Back in my behavior analysis days, we used to have this saying that said, if you were bowling and a curtain came down just before you hit the pins, would you continue to bowl? And I think most of us would say no. We need some sort of reinforcement and some sort of feedback regarding how we're performing. So it's important to give the providers frequent feedback regarding their performance. Even if it doesn't seem like the needle has moved that much, a month-to-month type of revealing, if you will, of performance data can be very, very important. And so we highly recommend having access to that information and sharing it with the providers. It can be very labor intensive, but we think well worth it. And then last but not least, helping them understand if at the end of the day, you really don't want to play, or we don't want you to play, there's always the ability to part company. And that's a tricky one because obviously we lose the attribution. Even if we want it to happen, there's the ongoing legacy that provider needs to report on quality measures. So it's how to strike a balance. We often have penalties in our provider agreements that say if you leave, this is the penalty. But again, we try to balance that against the ongoing responsibility for which they're contracted.
So the nuance with an ACO is that the quality reporting happens after their performance year. So the most important point when we separate from a physician is that they must absolutely submit GPRO the following spring, or they 100% will forfeit shared savings. A lot of scars on our back by not having it so conspicuously communicated. And then, just a quick update on here is, you owe it to your ACO and your hardworking physicians to communicate participation expectations. So, this is an example of the work that we tell a new participant that they have to do. But, we owe it to the hardworking doctors, because if we bring on a new physician and they don't perform, it takes away from the performance payments of the others. So we communicate this early and often.
Nice. And these are some snapshots from their own contracts, and I think they're really good takeaways. So we will then move into TIN due diligence. So when you want to bring on a new practice, what do you have to do? What are some methods? And you could always do some sort of survey. They have URs available, quality resource and use reports that CMS spits out. And you probably want practices that have high quality, low cost in that upper right-hand quartile in that picture. But you could also take a look at your existing network. Some of you might be a part of clinically integrated networks, and maybe your ACO is just a small subset of that entire organization. It's a great way to just take a look at how are the providers performing in your network, your larger network, to include them in your accountable care organization. And then there's a line here that talks about comprehensive office review. This is something I did prior to working at Salient, but we would actually go into a practice and try to identify exactly how they're utilizing the office staff. Being a part of an accountable care organization means you're working as a team. It doesn't mean you're using medical assistants as people who are taking care of the garbage. It means you're incorporating them into the entire process and plan. The front desk staff should be watching the waiting room and seeing if there's any clue or key into someone having improper health. So really taking a look at how the office is being utilized as a team. And then lastly, you have that option of referrals. Referrals are the best way to incorporate a new provider into the practice. Physicians are buddies with some other people, maybe nearby, and they know who to work with and who not to work with. So just working with your own TINs that are a part of the practice is a great way to figure out who should be a part of your overall network. And I'll let David and Marsha talk about some of the other points here as well.
So we're very open with new participants. The goal of this analysis is to catch the 3 out of 100 that are going to really hurt you. But the key is making sure you're monitoring those surveys. So if you have a physician that's completely unwilling to change, if you have a physician that has some really unique acute place of service that they're bringing in patients that'll make them look bad, or they're very dedicated to their ancillaries, you want to catch them in the survey, because you'll be sorry potentially if you work with them. And then the other thing is, the public data has gotten so much better, and you can use a tool like Salient with your Medicare claims or the public data to screen practices that will potentially look very bad, particularly in the regional benchmarks. So if you kind of take a subjective and objective approach, you'll be able to catch the few physicians that just aren't an ACO fit.
For sure. And then in terms of background checks, we've seen ACOs exercise strategies all over the board. From the minimal, which is take a look at the CMS excluded providers list, which obviously you ought to do, early and often, all the way to engaging in almost a formal credentialing process that would include a full background check. So the continuum is pretty broad in terms of the background checks. To David's point, I think it's important that you really understand a few basics. To Amy's point, I think it's important that you understand as much as you can about performance. But what we typically do is recommend a minimum of obviously looking to make sure they're not on the excluded providers list. We also love it if we can get permission from them and we can do a peek into PACOS just to see if there's anything nuancy there that might come into play that could be problematic for the ACO. And then typically a malpractice loss run, which gives us a little insight to how they're performing from a malpractice perspective. Because keep in mind, that group, if you go back to one of the points we made earlier, that particular provider may be in the group around which malpractice insurance group coverage is being quoted. So it's important to understand that.
Yeah, absolutely. So we're going to wrap it up with our future thoughts, and I'll let David take it away with the first point.
So absolutely. So as soon as it says future, the disclaimer here is opinion. Yeah, don't hold me to this. But I feel like as a business model and, as a profession, ACOs, we have plenty of runway to perform. So, we're required to go risk now. So, it's really our role to take these next 5 or 6 years to take advantage of the better incentives and to really perform under downside risk. So I think the program will change slightly, but really it's just up to us to perform and make sure that the Medicare program stays afloat. The other big thing that we're observing is the CIN business model is potentially phasing out. Now, what I mean by that is specifically the one component of the CIN, which is collective bargaining. So, IPAs, ACOs, Super CIN, they often do very similar things. But it seems like locally here that if your business model is just to collectively bargain better contract rates because you're large, that seems to be phasing out because folks don't want to pay more unless you're better. So we're seeing the CINs in our market, and we're seeing the big fee-for-service providers in our market transition from the CIN model to at least some or all of it is value-based.
I would agree. And then from my perspective, I think we'll continue to see telemedicine play a big role in providing access to care. Obviously, many of our providers want to get back, many of our patients want to get back to an office-based environment, and that's most ideal, we believe, in terms of really providing the highest quality of care. Is face-to-face, true face-to-face access with the patient, but we think it's here to stay. And we think that it's a lot of it will help us with regard to being able to maintain a more ongoing relationship with that patient, more frequent check-ins, more frequent ability on the patient's side to ask questions that will keep them from going to the emergency room and thus being hospitalized, et cetera. Post-acute care is going to be a biggie. It's a biggie now, and it's kind of like the golden ring going forward. We believe how to manage costs, how to manage care in the post-acute arena, and then the emergence of remote patient monitoring, technology-driven, but how to take care of that patient remotely, and obviously telemedicine is a piece of this. But having access to ongoing vitals. Having the ability to remind patients so that they're more compliant with their care plans. We think that is taking off, and it will continue to get traction as a way to deliver care.
Thank you, Marsha and David. So that leads us to questions. Garrett, do you want to take that away?
All right. Thank you, guys. Again, that was very, very helpful and informative. We did have a number of questions that came through. And so I will, in no particular order, I don't think we're going to have time to get to all of these, but I'm going to go ahead and ask as many as I can in the allotted time. The first question is, are there any strategies for managing across state lines, and how do state laws interfere?
Okay. Some of our, I can take that one start. Some of our ACO participants are across state lines. So we found that the challenge with going across state lines is, yes, indeed, there are some state law issues, and they're state by state, and they're often around, how physician groups must be organized, et cetera. So just understanding those before you opt into going across the state line is very important. Understanding that when you're trying to determine and in any way try to predict what's going to happen with benchmarks, understand that you have different benchmarks in play. So it's more of a complicated equation, if you will. Also, not for nothing, it's often more difficult to provide services across state lines, even though a lot of the services can be provided remotely. When you're looking at any kind of face-to-face, boots on the ground type of support for the providers, then you're looking at the cost equation going up. However, I think it's an excellent way to somewhat diversify your portfolio, if you will, as an ACO. It's an excellent way to learn about different markets and what they might have to offer. So thus far, we've seen the challenges, but we think the benefits outweigh the challenge. But back to the state licensure question, I think it's just important to understand the state laws before you opt in to inviting a participant. In some cases, we've opted to actually set up a separate ACO in that particular geography, as opposed to include them in an ACO that has more of a national reach.
Great. Okay, moving along. Next question, and again, we won't be able to get to all of these, but I'll just ask a few of them here. Is and I guess this is directed at Mr. Klebonis, is as a large ACO, do you purchase stop loss or other insurance products to reduce your risk?
Oh, good question. So, we're a network of providers, and, insurance is not our specialty. So, we kind of count on the shared risk model, which does include some stop loss, and we really count on our physician performance to mitigate the risk. So, there are some folks that spend money on insurance, but, we'd rather spend money on performance. So the answer to that one is no. We keep to our strengths, which is having the best doctors in our county.
Okay, great. Next question is, what are your recommendations about using chronic care management?
So I can take a crack at that one, and David, please chip in. But chronic care management is obviously an appropriate way, and has a reimbursement associated with it as well, to take care of those patients who've been identified as needing that level of support. So what we try to carefully do is not say chronic care management needs to be implemented across the board. So every patient that has 1, 2, or more chronic disease states needs to be under chronic care management, because let's face it, in a lot of cases that would be your entire population. And some patients just aren't suited for that for a number of reasons. And obviously the costs associated with that can be pretty costly, and can actually impact your cost management program in a pretty significant way. So we use data to identify those patients that we feel like programmatically would be most appropriate for the programs that we're going to implement under our cost management umbrella. And then we determine of that population, what of those patients are frequent flyers in the ER, that they're going to the hospital more often. It just appears that they're truly unmanaged. So we try to look at those patients first, getting them on chronic care management, making sure that our chronic care management program is being effective. So we're really moving the needle, both in terms of cost management and also in terms of improvement in quality of care, and then before we expand it to the larger population. So again, summary, not for everybody. We don't encourage everybody to be on chronic care management. We're very selective, and we use data to help us make the decision as to who.
And just to chime in, we've been working with Marsha and her team to really identify those cohorts, those very specific cohorts, and try to filter out some of the reasons why you wouldn't want them a part of that chronic care management platform, or just enrolled in general. So really being able to cohort is a huge factor in care management, being able to figure out exactly who would have the highest return on investment and who would benefit the most from it.
Great. All right. One last question, and then we'll have to wrap it up. And this one is there a difference between rural and metro physician recruitment methods?
Marsha, you want to take that one?
Sure. I think there is. And so in terms of the differences between the strategies, obviously, if you look at what's going on, typically there are a lot more options for the metro type physicians. And the way that they deliver care often is a lot different than it might be in a rural environment. The options around referring physicians and facilities, et cetera, is a lot different. So we really try to look at, once we've identified that a practitioner would be appropriate for ACO, try to look at their patterns of practice. To whom are they referring? What's driving most of their spend? And is that because it's their only option for that geography, or is it because that's their preference? So I think that with the rural physician in particular, I think it's a little more challenging, because if you're trying to change certain behaviors, certain practice behaviors, or certain referral behaviors based on quality and cost, the options may be different. So I would say that the rural physicians in some cases need an ACO the most, but in terms in our
Okay. I think we were having some sound issues there. Thank you, Marsha. We're going to go ahead and wrap up now. And unfortunately, we are out of time. We had a lot of questions that came in. So thank you again to our panelists and to Amy for moderating that. It was very, very good and very useful. And for the questions that we weren't able to get to today, we'll make sure to email you afterwards and answer your question accordingly. As we conclude, I'd like to encourage you to visit the Salient Healthcare exhibit booth at acoexhibithall.com. And you can learn more about them there and connect with their team. And this is open 24 hours a day, 365 days a year. So come and visit them there. And also at acoexhibithall.com is where the recording of today's session will be and the slides for download in the reference library there. You can search for webinars. Lastly, if you have any specific questions for Mr. Klebonis or Ms. Boggess or Ms. Koch or the Salient team, their contact information is here on the slide, and feel free to make a note of that and to contact them directly. They'll be happy to follow up with you for further discussion. And we'll leave this up here on the screen for a couple minutes so you can get that. But thank you all so much for attending. I hope that you found today's presentation informative and helpful, and hope you have a great rest of your day. Stay safe and stay well. Thank you.